I'm going to tell you today why your heel pain is not getting better. It's very simple. It's not getting better because you are only addressing one half of the equation of the problem. The problem with heel pain is that there's two problems, not one. Problem one is being addressed, but the second problem isn't being addressed. So in this 10-minute video, I'm going to explain to you the second problem, which is impeding your ability to get better on its own. So coming up with a diagnosis of plantar fasciitis is the easy part. The hard part is fixing that nerve problem, which is the second problem. Every single patient, I've been doing this, I'm a foot surgeon in Manhattan, New York for the last 30 years, and every single patient that's come to see me has both a nerve problem and plantar fasciitis. So we're gonna talk about the nerve problem in this video. And at the end of this video, I'm gonna give you the opportunity to maybe even look me up and see me for personalized care, or I'm gonna give you my personal clinical framework that I've been utilizing for the last 30 years. And I put it together in a 5-point educational protocol for you. So at the end of this video, I'm going to give you the opportunity to receive that and utilize that. Now, let me say, I am a surgeon, but this is purely an educational video. It is not meant to take the place of your own private medical care that you're receiving at home. It is purely educational. It's not made to replace that relationship. So keep that in mind while we discuss this condition. Now, plantar fasciitis, it's the easy part. That is the micro ripping and tearing of the plantar fascia. That is the micro ripping and tearing of the Achilles tendon. That is the micro ripping and tearing of any of the fascial structures as it encapsulates like a bird's nest around the heel bone. Any of those fibers microtraumatically ripping and tearing is the component of plantar fasciitis or an Achilles tendonitis or an enthesopathy of the Achilles. That's the easy stuff, and it's actually in the process of trying to rid you of your problem. But again, it could be lengthy, it could be present for a long period of time. I've had patients who have had this problem for up to 12 years. So that is the problem that we're all aware of. That's the problem that all doctors get right. It's the second problem that I want to speak to you about that is much more complex. And it's present in everyone. Every single patient that I've seen in 29 years in my practice has a neurological component associated with that musculoskeletal component. That neurological component is nerve inflammation. It's nerve aggravation. That nerve, the crux of the problem is that that nerve is causing the plantar fasciitis. It's causing the weakness of that structural problem that you have of the plantar fasciitis or the Achilles tendon. The nerve, when it's irritated, it follows its normal anatomical path right next to the heel bone, right next to the plantar fascia, right next to the Achilles tendon. And when it's irritated, that nerve controls the circulation around these arteries and veins. And if that nerve is irritated, it loses the ability to maintain that tonicity of that vascular structure. So it increases the circulation to the extremity. By increasing the circulation to the extremity, it's like a fire hose. That fire hose is washing away those ions that allow for structural stability of those structures. That is the reason why plantar fasciitis comes back over and over, or may not even improve. 10% of the physicians out there are identifying that problem, and they're very astute clinicians. But they're also missing a second component of that, or they're addressing only half of the problem. I find that almost all of my patients have nerve problems that are stemming from the back. I know that if I don't address this nerve problem of the back, that I can put the fire out. Now, nerves are electrical entities. There's no such thing as one nerve that's being aggravated. It's one big electrical grid. It's like a spider's web. There could be an insult anywhere in the system. Anywhere in that web, there's an insult, and the whole system reverberates and feels it. Now, it's those reverberations that end up in the upper extremity in some individuals, causing carpal tunnel syndrome and other problems, musculoskeletal problems in the shoulders, the elbows, the wrists. But those reverberations at minimum are going to be found down at the lower extremity, and we've got a much greater demand being placed on that lower extremity. We walk 10, 12, 15,000 steps per day. If those nerves are reverberating, if they're inflamed, they're going to get worse. So we're going to have a neural component that causes the disruption of the plantar fascia, and we're going to have a neural component that's causing some symptomatology as well, causing us pain, discomfort, irritation. It's going to add to it. If a nerve is aggravated, it's going to cause a hypersensitivity. So the ripping and tearing of that plantar fascia is going to be accentuated. And quite often I'll see other musculoskeletal ailments that are accentuated. We may have bumps on the foot, things like bunions, hammer toes, corns, Taylor's bunions, Haglund deformities. These deformities are all predominantly accentuated, magnified, because we have a hypersensitive nerve that's contributing to the problem as well. Now, the nerve problem, we're going to appreciate with things like numbness, tingling, pins and needles, burning, shooting sensations, cramping, pain at rest, pain at night. These are the pathognomonic markers of nerve inflammation. So if we have those conditions, we know definitively we have a nerve problem that's accompanying the condition. However, sometimes we have a very subtle nerve problem, and that nerve problem is barely appreciated. How I figure it out is I ask you those pathognomonic markers. If you say yes to one of them, I know definitively there's your answer as to what degree or what level that nerve problem is at. If you say yes to all those things, boy, you've got a really bad nerve problem. And there's always a ratio between the plantar fasciitis and the neurological condition. Some patients are 80% plantar fascial and only 20% neurological. Now, those patients are going to do quite well, and you're probably not even here trying to figure out why your heel pain won't get better. And the answer is because that musculoskeletal system is easy to fix. You'll respond to arch supports, oral anti-inflammatories, injections. However, if we're somewhere around the 50-50 mark or 70-30 or worse, that nerve problem is going to continue to contribute to the problem that you now have. And it's that nerve problem that is being lumped in as plantar fasciitis that hasn't been addressed, which is why you're experiencing your problem so significantly and why you failed all types of care. So that ratio is important in trying to figure out. Now, the other way of figuring it out is simply what I do is I go up to your radial nerve and ulnar nerve of the upper extremity and palpate them with a non-painful stimulus. I do the same exact thing to the lower extremity, and we identify your nerve of the side that's giving you a problem. I'll palpate it. If it's a really bad nerve problem, I'm going to find it immediately. I'm going to put a non-painful stimulus on it, and you're going to withdraw that foot away from me. If it's moderate, same thing, but just not as severe a response. Sometimes it's exceptionally mild, and in those exceptional miles, it's hard for me to find, but I find it in everybody. And I compare it to the opposite side. The opposite side usually has a little nerve inflammation as well because, again, the whole tree is being triggered. So this is the nerve problem that's associated with this condition. Now, the nerve problem that we have down here sometimes occurs with an overt back problem. Patient goes, oh yeah, definitively. I've had a back problem for a long period of time. Herniated discs, sciatica, motor vehicle accident, traumas. They have a definitive back problem. That is evidence, again, that the whole system is aggravated, or we liken it to two fires. Fire down here in the kitchen, which is the foot, fire up here in the bedroom, which is the spine. Now, if you call me in to take care of, which is what the vast majority of doctors are doing, is they're putting this fire out down here, or that 10% that's addressing the nerve problem. They'll put that fire out down there, but it's going to be short-lived because they didn't address the problem at the back. The back is often the key. That's what prevents it from ever coming back again. So how do I treat this? I treat this by bringing in, typically on a Friday, we give you a little medicine in the arm, my anesthesia team. It's called IV sedation. You're going to feel like you had three or four glasses of wine. Your eyes will be open. You'll be awake, conscious talking. And what I do is shockwave, delivering a impulse, a sound wave that's going to hit that heel, and it's going to recruit more inflammatory cells in the area. Your body is responding with an inflammatory response, but it's just not enough. What this will do is it will augment that response and aid in the healing process. It's only got about a 50% success rate, so we have to add more to it. So what I do is PRP. I take blood from you, I spin it in a sophisticated centrifuge, separate non-healing cells from healing cells, and I take those healing cells and I administer it into and where about the plantar fascia is disrupted, where it's ripping and tearing. Third thing I do is I give you directed nerve block. I give you an anti-inflammatory around the nerve. That shrinks the nerve. So one pathophysiological feature of the nerve is that it becomes hypertrophied, it becomes enlarged. It gets compressed and squeezed and it becomes bigger. And we develop a vicious, ugly cycle. That's, again, the reason why the nerve won't get better. Two is nerve has pain gates called sodium potassium ATPase channels. And when I experience a painful stimuli, I withdraw my hand, which has happened is these gates opened up. They allowed for ions to come in and out, and it told my brain to tell my arm to remove itself from that impulse. Did so in a nanosecond, and then they fired shut. Somebody with nerve pain, the gates are left slightly ajar. So what I do is I give you, number one, a anti-inflammatory around the nerves, which shrink them. If I shrink it by 1/100th of a millimeter, we get relief. And if we get relief, we get further shrinkage. We start getting a positive feedback loop. I close the gates. I give you a medicine, lidocaine. It's what your dentist gives you here in the mouth, closes those gates definitively. Once they close, we've reestablished those communications, and the nerves like this better than this. This is overexcitation. So we address those nerve components through that. After that, it's about a 5-minute, 6-minute, 7-minute procedure. You're able to run and jump after we're done. If you're an avid athlete, like some of my patients are, my marathon runners, for instance, I'm going to ask them, please do not start running until about the 3 to 5 day mark. So if you're in New Jersey or New York, my primary location is 61st Street and Park Avenue in Manhattan, you're more than welcome to see me for personalized care, and we'll review those advanced modalities that I just discussed. You're welcome to give us a call and get a telemed appointment, and we can discuss it by way of telemed. Or, again, what I've done is I've put together a 5-point educational protocol that comes from my personalized clinical framework that I've established over the last 29 years. You're more than welcome to receive that, but it's a $50 charge. And what that does is it's going to give you those 5 points. One, I'm going to work on, most importantly, the curvatures of the spine. We're going to give you exercises that you can do in your living room that's going to restore those curvatures. You need to do it the rest of your life, 5 days a week. Incorporate that into your livelihood. Second thing I'm going to do is I'm not going to offer you an arch support, an expensive $400 arch support. I'm going to offer you something else that goes inside your shoes that's going to be just as effective, probably more effective, at reducing the nerve inflammation and reducing the plantar fascial ripping and tearing. An arch support oftentimes makes your nerve problem worse. Third thing I'm going to do is I'm going to offer you some nutritional support. I'm going to recommend some vitamins and nutrition that's going to make the neural component better. I'm also going to offer you a physical therapy modality localized to the foot and ankle that's going to reduce the inflammation and reduce the inflammation of the nerve and inflammation of the plantar fascia. And lastly, I'm going to give you some recommendations for you to discuss with your doctor to get the right medications. Often non-steroidal anti-inflammatories, the ibuprofen, the Motrin, the Advil, they don't work. They don't touch a nerve problem, but it's something else, okay? So I'm going to recommend that. I'm going to give you a template to give to your doctor, and you're going to review that with him, and it's going to discuss my recommendations.